Thanks for joining. In this video, we are going to review systemic inflammatory response syndrome, also known as SIRS. We will discuss SIRS criteria, etiology, pathophysiology, and how it manifests in our patients, potential complications of SIRS, various treatment options, and how to apply this information into clinical practice. So what is SIRS? SIRS is an overwhelming inflammatory response that occurs within the body as a result of tissue damage from infectious or non-infectious sources. The use of SIRS criteria can often be seen in emergency triage settings and acute care settings where it is used for early identification of sepsis. SIRS can be triggered by mechanical tissue trauma such as burns, crush injuries, and surgical procedures, severe dehydration, ischemia, as we often see with myocardial infarct and vascular disease, shock due to inadequate tissue perfusion, significant immune reactions such as anaphylaxis, infection due to bacteria, viruses, or parasites, and pancreatitis. In order to meet SIRS criteria, patients must have at least two of the following findings: a temperature greater than 38 degrees Celsius or less than 36 degrees Celsius, and here it is important to recognize that hypothermic body temperature can present after massive trauma and can also be a sign of inadequate immune response, especially in our elderly patients. Heart rate of greater than 90 beats per minute. Typically, we would define tachycardia as a heart rate greater than 100 beats per minute, but with SIRS it's 90. Respiratory rate greater than 20, or a partial pressure of CO2 less than 32 millimeters of mercury. Normal CO2 levels tend to sit between 35 and 45 millimeters of mercury, so this decrease in CO2 is reflective of a respiratory alkalosis. And finally, a white blood cell count greater than 12 or less than 4, or more than 10% band cells. And band cells are immature neutrophils. A high number of band cells is going to reflect the body's attempt to rapidly produce cells that are geared to fight infection. Lab values here. Please note that SIRS criteria and lab values differ among the pediatric population, so for the purposes of this video, we're going to focus on adult lab values. If we think about SIRS as a predictive criteria for sepsis, SIRS would be the clinical state that begins the sepsis continuum. SIRS can progress into sepsis, which is a systemic response to an infection. As sepsis progresses, septic shock can develop as hypotension significantly impairs tissue perfusion. Without oxygen and nutrients, organ systems within the body begin to fail. Multiple organ dysfunction syndrome, or MODS, is the failure of two or more organ systems to such a degree that homeostasis cannot be maintained without intervention. So identifying the risk for sepsis is especially important in the SIRS stage, as the body is still able to compensate at this point. I want to make the distinction between SIRS and sepsis. While patients with sepsis often have SIRS, patients with SIRS do not necessarily have sepsis. As we see in this diagram, SIRS has many non-infectious causes, while sepsis is characterized by at least two SIRS criteria, as well as a suspected or confirmed infection. Due to the general nature of SIRS criteria, incidence tends to be high among hospitalized patients. One study noted 47% of patients met SIRS criteria at least once during their hospital stay. Mortality rates were 4.3% higher in patients who met SIRS criteria than patients without. The prognosis for patients with SIRS and MODS is poor. Mortality rates are 70% to 80% when 3 or more organs are involved. As a predictor of sepsis, SIRS criteria can help prevent death and decrease hospital spending, as the Canadian Sepsis Foundation estimates sepsis affects 18 million people worldwide and is responsible for $325 million in annual spending in Canada alone. The CDC reports 1 in 3 people who dies in hospital has sepsis. That being said, the use of SIRS criteria is not universal. In 2016, a task force consisting of the European Society of Intensive Care Medicine and the Society of Critical Care Medicine removed SIRS criteria from the sepsis guidelines. The characterization of severe sepsis was also removed. SOFA criteria was added, as you can see in this table. Diagnosis of sepsis requires a systolic blood pressure less than 100 millimeters of mercury, respiratory rate greater than 22 breaths per minute, and a GCS score less than 15. This quick assessment can be done at the bedside as there are no lab value requirements. However, the utility of SOFA scoring is questionable in ICU settings where patients may be on mechanical ventilators and vasopressors. Despite the controversy, strong support for SIRS remains among the Canadian Association of Emergency Physicians. In order for SIRS to occur, there needs to be a disruption of tissue integrity. Inflammation occurs when a physical, chemical, or infectious injury damages body tissues. Inflammation usually serves as a defensive reaction intended to neutralize, control, or eliminate the agent of injury and prepare the body tissue for repair. It's important to note that inflammation and infection are not synonymous. An infectious agent can trigger inflammation. However, inflammation can also result from injury, ischemia, and immune responses. In order to understand the systemic manifestations of inflammation, we'll first review inflammation as a localized response. Regardless of the agent of injury, the 5 cardinal signs of inflammation, erythema, heat, swelling, pain, and loss of function can be attributed to the following inflammatory response mechanisms. The vascular response includes increased platelet aggregation, vasodilation, and hyperemia, or an increased flow of blood to the site of injury, and increased capillary permeability. This process is designed to minimize bleeding, trap bacteria, and provide the framework for healing. As fluid continues to leak out of the vascular space and into tissues, white blood cells, red blood cells, and platelets are trapped within the vessel, increasing the blood viscosity. An increase in white blood cells, such as neutrophils, can be seen in patient lab values in the early stages of infection. Neutrophils arrive approximately 6 to 12 hours following the inflammatory response activation. Neutrophils tend to have a relatively short lifespan, approximately 24 to 48 hours. So as they die, the body and bone marrow attempt to keep up with the demand. Increased band cells, or the immature form of neutrophils, will be seen in lab values. This increase in band neutrophils is often referred to as a shift to the left. Monocytes arrive approximately 3 to 7 days later, and their primary function is to clean up cellular debris. As white blood cells die and accumulate, their debris can form exudate or pus. Chemical mediators such as histamine, kinins, and prostaglandins are also released during injury and are responsible for changes to vascular permeability, vasodilation, and the contraction of smooth muscle, including in the bronchioles. A systemic progression of inflammation can occur when the body's pro-inflammatory agents outweigh the anti-inflammatory agents that are designed to stop the cascade of inflammation. Signs of systemic inflammation include increased body temperature or fever, malaise, loss of appetite, muscle aches, weakness, increased heart rate, and respiratory rate. Patients at risk for developing SIRS include those with poor health, such as multiple stressors or comorbidities, nutritional deficiencies like low protein or vitamin C, healthcare providers due to exposure of infectious agents, patients who have undergone recent trauma or surgery, patients of extreme ages, diabetics, those with infection, presence of invasive lines, and immunocompromised patients such as those receiving chemotherapy. Due to the general nature of SIRS criteria, it's important to consider how a patient's medications or comorbidities can affect the assessment. For example, a patient using beta blockers may not exhibit tachycardia. Lack of SIRS findings does not negate the potential for sepsis. Nursing diagnosis for SIRS patients are going to reflect the patient's clinical presentation and the underlying etiology of the SIRS response. For example, hyperthermia, pain, and impaired gas exchange may present in patients who meet SIRS criteria. The patient is at high risk for developing an infection if it's not already present. Hypoperfusion due to increased blood viscosity, potential microemboli in small vessels, decreased blood pressure and fluid volume, leading to shock due to the plasma and protein shift outside the vascular space. Early recognition of SIRS criteria and risk for sepsis is the key to preventing progression along the sepsis continuum. Assessment should include a detailed history and physical, including recent travel, use of new medication, exposure risks, food intake, recreational drug use. Physical examinations should be thorough and focus on identifying sources of injury or potential infection, as well as the extent of any potential organ involvement. Vital signs should be repeated regularly to detect even subtle changes in oxygenation and tissue perfusion, level of consciousness, renal impairment, ecchymosis, or hemorrhage. Patients who meet SIRS criteria are highly susceptible to infection. Hand washing and strict aseptic technique are important when providing care. Treatment of any infection must commence early. The maintenance of tissue oxygenation is essential and may include continuous O2 monitoring, oxygen supplementation, rest, analgesics, and in some cases, sedation and mechanical ventilation. SIRS effects can result in hypermetabolism as the body's total energy expenditure increases 1.5 to 2 times its normal metabolic rate. This can lead to weight loss, muscle wasting, and organ failure, but will be immediately evident in increased heart rate, increased respiratory rate, and hyperthermia. If nutritional support is required, enteral feeding is preferred over parenteral feeding. Serum protein, nitrogen, glucose, electrolytes can also be monitored to detect signs of hypermetabolism. Communicating findings in a timely manner is essential in reducing risk for sepsis and organ failure. Preliminary diagnostic tests are going to include lab work, such as CBC, arterial blood gases to monitor blood pH, as the progression of tissue damage can lead to metabolic acidosis, lactate levels, greater than 4 millimoles per liter indicates tissue hypoxia. Blood glucose levels can be elevated in non-diabetic patients due to stress and the inability to reach target organs due to hyperperfusion. Cultures of blood, sputum, and urine should be obtained prior to antibiotic administration to detect infection. Cardiac monitoring can include ECG and continuous cardiac monitoring to note any developing cardiac dysfunction. Chest X-ray, as the lungs can be a source of infection, and patients are also at risk of developing acute respiratory distress syndrome. Finally, hemodynamic monitoring will detect changes in arterial and venous pressure. Mean arterial pressure should remain above 65 millimeters of mercury. Treatment goals for our SIRS patients should include preventing infection if not already present, treating the underlying cause, minimizing patient discomfort, and preventing organ failure. Nursing interventions are going to include treating and preventing infection, including antibiotic administration, wound care if applicable, removal of invasive tubes, and using strict aseptic technique for all procedures. Vital signs should be performed at least Q1 hour or more frequently if warranted. O2 supplementation as necessary and IV fluid administration. Monitoring urinary output. Providing pain control. Analgesics reduce patient stress, respiratory rates, promote mobilization, and enhance feelings of wellness. Patients' mobility should be encouraged as tolerated to prevent deconditioning, lower the risk of DVT, and mobilize pulmonary secretions. If specific deficits are noted, it's important to support the failing organs. Pharmacologic treatments can include antibiotics, as in SIRS infection must always be suspected. Start with broad-spectrum antibiotics and narrow or discontinue use as culture results come back. Anti-inflammatories, such as NSAIDs, are used to treat inflammation. NSAIDs should be used with caution due to the risk for acute tubular necrosis, and monitor your patient's renal function closely. Corticosteroids may be helpful in reducing systemic inflammation for some patients as well. Analgesics to relieve pain and provide antipyretic effects. And anticoagulants may be used to reduce the risk of microemboli and DVT caused by platelet aggregation and increased blood viscosity. Vasopressors and inotropic drugs are used if the patient's blood pressure drops and does not respond to IV fluid resuscitation. This is known as refractory hypotension, and mean arterial pressure should remain greater than 65 millimeters of mercury. Crystalloid fluids are the IV fluid of choice for SIRS patients. Normal saline and Ringer's lactate are the initial fluid of choice. However, with SIRS progression, Ringer's lactate should not be used as the failing liver cannot convert lactate to bicarbonate, further increasing serum lactate levels and metabolic acidosis. Colloid fluids such as albumin may be used as volume expanders and reduce fluid leak due to the change in oncotic pressure. Patient teaching should focus around preventing tissue injury and infection. Hand hygiene can help reduce transmission of microorganisms that cause infection. Postoperative or hospitalized patients should be taught the benefits of deep breathing and mobility to decrease risk of DVT and mobilize pulmonary secretions. The importance of regular vaccinations, especially during flu season, and taking additional precautions when traveling outside the country. Patients should understand signs and symptoms of infection and DVT and not delay medical care if needed. With injury, pain management may be required, as well as relaxation techniques to reduce stress. SIRS complications can include acute respiratory distress syndrome, or ARDS, cardiovascular dysfunction, disseminated intravascular coagulation, or DIC, renal failure, gastrointestinal dysfunction, and multiple organ dysfunction syndrome. As the progression of SIRS to sepsis can happen very quickly, guidelines for preventing sepsis are indicated within the Surviving Sepsis Guidelines. Within the first 3 hours, a serum lactate level should be taken. Obtaining blood cultures before administering antibiotics, though the administration of antibiotics should not be delayed, and administering crystalloid IV solution for hypotension or if the lactate level is greater than 4 millimoles per liter. Within the first 6 hours of care, vasopressor agents for refractory hypertension may be given to maintain mean arterial pressure greater than 65 millimeters of mercury. In the event of persistent arterial hypotension despite volume resuscitation or septic shock, or initial lactate levels greater than 4 millimoles per liter, measure the central venous pressure, and measure the central venous O2 sat. Lactate levels should be remeasured at regular intervals. And it is important to communicate any changes in patient condition in a timely manner. So here we'll apply this information into our clinical practice. A 45-year-old female patient presents to the emergency department with complaints of abdominal pain, nausea, and vomiting for the last 24 hours. Past medical history includes hypothyroidism, treated with Synthroid, and asthma, treated with Flovent and salbutamol. Surgical history includes laparoscopic cholecystectomy 2 weeks ago. On assessment, the patient is alert and oriented ×3, skin is clammy. The patient reports 8 out of 10 diffuse abdominal pain with guarding noted. Lap site incisions ×3 are approximated with less than 2 centimeters of erythema noted around the epigastric incision. Triage vital signs include a temperature of 38.5, blood pressure of 102/45, heart rate 110, respiratory rate 22, and SpO2 96% on room air. Does this patient meet our SIRS criteria? The answer is yes. Additional assessments for this patient include patient is alert and oriented, complaining of pain and nausea, decreased air entry to right lower lobe with inspiratory coarse crackles, splinting, and no identified sputum. Abdomen is distended with tympany, hypoactive bowel sounds, and no flatus. The patient reports dark amber urine, last void unknown. Poor skin turgor and dry oral mucosa is noted. Preliminary lab results reflect an elevated white blood cell count, a low potassium level. BUN and creatinine are also high. Chest X-ray reveals right lower lobe infiltrate, and the abdominal X-ray reveals dilation of small bowel loops. Based on the patient's positive SIRS criteria and suspected source of infection, the nurse should communicate findings in a timely manner, monitor the patient's vitals and reassess regularly, anticipate administration of antibiotics, initiate IV, and provide fluids as necessary, monitor oxygenation and cardiac function, determine the source of infection by obtaining cultures prior to antibiotic administration. It's important not to delay antibiotic administration. Further labs may be requested, such as serum lactate level, glucose, arterial blood gases, and estimated glomerular filtration rate. Monitor the patient's intake and output. Catheterization may be required. Provide additional support for increased nutritional and metabolic needs. Provide the patient with emotional support and patient education. You may also provide the patient with analgesic as necessary, and reassess the patient's condition frequently, ensuring that all new findings are reported immediately. Thank you for participating in this presentation.